Hai sahabat Doktervito, hari ini kita punya tamu spesial ya. Hari ini kita akan bicara mengenai obesitas dengan seorang dokter yang mendalami obesitas. Langsung aja kita perkenalkan Dokter Rocio Salas. Dokter Rocio Salas, how are you?
I'm doing good, thank you, Doktervito. How about yourself?
Well, I'm very good and I'm very excited to hear from you. I'm excited to see that how we are now realizing that prevention is more than just treating patients. So I'm a cardiologist, and then I am actually a little bit exhausted to see many patients have a heart disease, and then we know how to prevent it. Actually, then one of the most preventable diseases is actually obesity.
So obesity, the concept of obesity has changed a lot in the last few years, and it's taking time to adapt to the new classification or concept of obesity, right? Before, we used to think that obesity is a lifestyle problem, right? It was what the person is doing right or wrong. But now we know that obesity, it's considered a disease. It's considered a chronic multifactorial disease, meaning that there's not just one thing causing it, and it's definitely not just lifestyle. There's many other factors that can contribute to obesity that the person doesn't have control of, right? And that's genetic, so family history, environmental. We know there's a lot of obesogenic environmentals, hormonal problems, aging, and then lifestyle, right? So all of those things can contribute for a person to gain weight or have obesity.
Now, here's one interesting thing. In Indonesia, in my place, so many people say that, oh, it's okay if you're obese as long as you're happy, or it's okay as you are obese but actually you're healthy, so it's okay to be obese. What do you think about that?
What happened in COVID? The pandemic made it clear that it's not okay to have obesity, even though you don't have disease, right? Because of the chronic complications of obesity can take 10, 20 years, right? And that's why people kind of were accepting obesity. As long as you're healthy, it's okay that you have obesity. But what happened with COVID pandemic? It showed us that no, it's not okay. There's a chronic inflammatory process going in obesity, and which patients had the highest mortality in COVID? Patients with obesity. Who were higher ICU stay? Patients with obesity, right? So no, it's not okay. And COVID had to come and show us that even though you haven't developed metabolic disease, right? We call it the metabolic healthy obesity. Even though you haven't developed metabolic disease, it still affected you, and patients were dying with COVID because there's a chronic inflammatory process going in obesity. And the inflammation keeps all your antibodies and everything so busy that when the virus came, you couldn't protect yourself to it, right? So it is not okay, and COVID brought it to attention.
So you have a strong message here that obesity is a disease.
It is a disease. The WHO, the World Health Organization, classified obesity as a disease in 1942. 1942, and the American Medical Association, 2011. So there's a huge gap, right, from when it was first mentioned as a disease to 2011 when it was accepted, even till now, right? There's many physicians, there's many healthcare that they still don't think obesity as a disease. And when we don't think obesity as a disease, then we don't treat it. We think it's upon the patient's responsibility, right? But we actually can treat it like diabetes, like hypertension. They are also chronic diseases.
So there is a story. So one of my friends, she got a medical checkup, and then the conclusion, that's written down that you have obesity problem. So she got offended. Well, actually many things happen in social media right now. When you talk about obesity, they will talk about it's a body shaming, or you shouldn't say that. So yeah, many people like denial to get obesity. So they think that it's actually normal to have obesity. You have to treat me as usual. What do you think about that?
It's a very, very fine line, right, of political correctness. Here in the United States is the same thing. And I always say it, and I always say it in my posts, and I always say it to my patients. I'm very pro accepting yourself, right, and accepting who you are. But we cannot normalize obesity, because then that's going to be a problem, right? We cannot normalize obesity. And we have to learn to separate the disease from the person, right? And it's also, even the language that we use is different now. We don't say the obese patient. We said the patient with obesity, right? We're not marrying you to that word. It's not you. You have obesity, not you are obese. It's a different thing, right? We have to separate those things. A diabetic doesn't feel offended, right? When we say that they have diabetes, they don't take it as something personal. And you can argue that there's some lifestyle contribution there, right? But we learn not to stigmatize that anymore. So we have to learn not to stigmatize obesity either, so people can feel free to seek attention, and healthcare providers offer attention. Healthcare providers are the #1 bias in obesity, right? There's so many articles saying that even doctors, nurses, when they see somebody with obesity, they already, in their mind, they're thinking they're lazy, they're going to fail treatment. They already put them for failure, right? So we have to change that mentality.
Okay, so that's very interesting, because we see the patient that have obesity as a problem. So we are not saying that you're obese. That's very good. And then you're saying that if people see patient with obesity problem, we're not seeing them like have a problem, like a failure. I mean, we have to help them actually. And then there is a thing that people sometimes they think they want to surrender. I mean, no. I mean, they think that, okay, my whole family is obese. My whole family is like this, so I could not achieve my body goals, so I could not be healthy because I have the gene. So what's the hope for them? I mean, I think you will have this perspective, and I really want to hear that.
It's true. I see it all the time in my patients. They've done everything they can. That idea of the lazy patient that has obesity and that they just prefer to be like that, it's a lie. When my patients come to me, they've done gym, training, diets that I've never heard in my life of. They spend decades trying to lose weight. So when somebody says, yes, I've done everything and I'm not losing weight, you have to believe them, right? But that doesn't mean that we cannot treat, right? We cannot just throw our hands up in the air.
Yes.
And here in the United States, we have the board certification in obesity, so we actually consider it a specialty now. Obesity is a specialty, and we have medications that we can use to treat obesity. We have FDA-approved drugs for the treatment of obesity.
Wow, this is very interesting part, and I know you are board certified in endocrinology and also obesity medicine. So what do you mean by treating obesity? Because most of people will think when you're treating obesity, it means you will have a diet schedule, or you will just eat a little bit and then you will suffer all the time, or you have to put yourself in a sweating pants every day. You are exercising, that's all. And whenever you fail to do that, you will say that, okay, I am off, will be obese because my whole family is like this. So you have hope for them.
Yeah.
What do you mean by treating obesity?
And medications, they work great. I mean, the medications are designed to target the problem with obesity hormonally, right? Because obesity, it is a metabolic disease, right? There's the hormones that influence hunger, hormones that influence satiety, feeling of fullness. So the medications that we use here target those hormones, right? It decreases the hunger hormone, it increases the satiety hormones. And some of the medications, the GLP-1s that we can talk about, they target the amygdala in the brain where the pleasure eating happens, right? Because we eat also not just for hunger, but we also eat for pleasure or for some emotional feedback that we get from food. And those medications has receptors in the part of the brain on the pleasure eating, on the reward eating area. And it just separates any emotional connection with food. So you really think of food only when you're hungry, but because it's also increasing your satiety hormones, you eat smaller amounts. So it teaches you how to see food and how to know when to eat just for hunger and not just for boredom, depression, anxiety. So they target hormonally receptors in your brain.
Oh, I think it is this very important part, even for physicians. So you are saying that the treatment of obesity, you're targeting the hormone and also the satiety center. I mean, the people like they feel satisfied when they're stressful on job, and then they will eat many things, you know, burger, French fries. So you can treat them actually.
Yes, and the medications are also, I mean, and this is something that it has to be mentioned, always recommended lifestyle, right? I mean, I always tell my patients, just see what things that you know that you can cut back on, right? But my view of diet, it has to be something that the patient will be able to sustain, right? I don't offer anything restrictive to my patients because it's not sustainable long term, and what you want is something that is going to be long term, right? So I always talk about balance in regards of diet. Whenever I put a patient on medication for weight loss, they ask me, what's my diet? And I said, let the medication guide you, because many of the things that may make you gain weight have an emotional connection, right? It's when you're stressed, you get a reward of happiness, of relief, and the medication will take care of that. You won't be craving for those type of food. But I always recommend my patients more into clean eating, so the less processed food, because we know processed food is obesogenic too. All the chemicals, all the endocrine disrupting chemicals that they can also promote obesity, right? So my view in regards to food is balance, but more leaning into less processed artificial food, more natural food.
Wow. So I got it now. Then I hope the audience got it too. I mean, it's not a shortcut actually, but the medication will guide you, and it'll help you to suppress your natural hunger, and it's make you easier to have a healthy lifestyle.
Yes,
it's like that. Exactly. Wow. It's very actually. I want to know more about this, and then I'm sure that our audience want to know more. So how about you think that people like they'll think that if you eat, it's actually make your mood good. So good food, good mood. How about that?
Yeah. I mean, and that's one question that sometimes my patients ask me. They ask me, am I still going to enjoy food? I mean, I have patients that are chefs, right? And they rely on their taste. They rely on that. And then you still enjoy the food. You still enjoy what you eat. But it's just you're not getting an emotional connection from, or an emotional reward from food, right? So you have more control of what you eat. So the medication actually really takes some of the control of you, and it guides you. It guides you when and how much to eat. It's really interesting, and it is very hard to understand the concept until when patients are on it and they come back and they say, now I understand what you're meaning, because it's such a foreign concept, right? That you're not going to control what you eat. And people with obesity have been controlling what they eat most of their life, right? No. So for them to let go of it, it's a little bit scary, but the medication does that for you. It guides you. It tells you when and how and what to eat.
So in your experience, how long until the patient have a strength to control their hunger? I mean, with the help of medication.
So, I mean, it depends on every patient. It depends on the amount of weight loss, right? I mean, I have patients that have lost 50 kilograms. So we're talking about a year on the treatment, right? I have patients that need to lose 5 kilograms, 20 kilograms. So it depends on the length will depend on the amount of weight that the patient has to lose, right? But these medications are designed for long-term use, because otherwise we're thinking of obesity as a lifestyle problem. Again, if I help a patient, I get them to their goal, and I stop everything, and I expect the patient to maintain it on their own, then I'm going back to the same concept, right? That it's the patient's responsibility, but it's not. Everything, all the genetic factors, the environmental factors, they will still be there. So we're setting our patients to failure, right? And again, these are all new concepts, that even here in America, they're new concepts. So whenever I have a discussion to a patient that I'm going to start on treatment, we have the discussion that it can and it should be used long term. That is not just while you lose the weight and then we stop. And that's another concept that the patients, is multiple steps, right? That I let the patient digest those things in their following appointments, right? But ideally, these medications are designed to be long-term, like diabetes. When we treat diabetes, we improve the glucose of the patient. We don't stop the drug. Same hypertension. We start a patient on the medication. We control their blood pressure. Do we stop the medication? No. Why? Because the blood pressure is going to go back up. Same concept with obesity. It's a chronic disease. We don't cure it. We don't cure it. We control it, as diabetes, high cholesterolemia, hypertension, as many others.
Will there a time then the patient will gotta stop? I mean, they could like, okay, I don't need this medication anymore. Maybe a couple of years. Is there any time for that?
Yes, there is, but I have to tell you that 99% of the time, that at the time after the time has passed, the patient don't wanna stop it. Okay. They all come, the majority come saying, no, I just want this temporary. I just want this until I lose weight and then I'll see how I feel. And when that time comes, it's like automatic. They don't wanna stop it because it helped them, right?
So yeah, that's the meaning of you say that obesity as a disease. I mean, we have to control it. I mean, and then just like diabetic and hypertension, it's all metabolic disease, just like obesity.
Yes.
Okay.
And very interesting, bariatric surgery, it's another way that we treat obesity, right? Bariatric surgery. Yes. But what bariatric surgery versus the medications, the difference, bariatric surgery treats the gut control, but bariatric surgery doesn't treat the pleasure eating control that the medications do. So I see many patients that had this leaf, that had bariatric surgery, that they regain weight, and then I put them on the medication. So you have to even question which patient requires bariatric surgery if we can actually treat them with medication now.
Yeah, because it's actually you're saying that it's like a natural hunger, and then your genetic. So it's play role actually. And then when you do bariatric surgery, it's actually you just minimize the capacity, but you don't change the mind, and then all the hormonal changes.
Exactly. And this medication targets the brain. It changes the thinking and the relationship of food that bariatric surgery doesn't.
And then when you tell us about how the medication will change, let's say your brain. So the audience will ask about, is there any like side effect that we should worry about?
Every medication, even an aspirin that you can buy in the pharmacy, can have side effects, right? And yes, these medications have side effects. But my view as a physician always, when I treat a patient, is I put things in a balance, right? Are the side effects worse than the benefits? Then I don't use. If the benefits are better than the side effects, then that's a drug that I will give to my patient. And that's with obesity drugs. The benefits, the long-term benefits outweigh any side effect that the medication can have. And most of the side effects are tolerable. The most common is nausea. And the nausea is more a feeling of getting used to fullness, right? Or on stopping when you feel full. So you can have nausea, which is tolerable. It can cause dehydration because it doesn't only take away your hunger, it can also take away your thirst. So patients consciously need to be drinking water, otherwise they'll become dehydrated and get very tired, dizzy, headache. I would say dehydration is worse than the nausea. It can also cause constipation because it's slowing down digestion. You're eating smaller amounts of food, and then the dehydration. So we can see constipation on that. And those are the most common and tolerable, right? They're not deal breakers for patients. Then there's also, it could cause pancreatitis because it also targets the pancreas. These drugs were designed for diabetes initially, but to work as a diabetes drug, you actually have to have an abnormal sugar. Your sugar, they're glucose dependent. So your sugar has to be abnormal to work as a diabetic drug. But if your sugar is normal, like in a non-diabetic, it doesn't do anything in your pancreas. So the pancreatitis that I've seen in my 12 years of experience with this drug have only been in diabetics, and probably 2 or 3 cases. So it's not common, and I've never seen it in a non-diabetic because it doesn't target the pancreas. So acute pancreatitis is one. And then there is mention of risk of medullary thyroid carcinoma, which is a very rare type of thyroid carcinoma. But in humans, it hasn't been shown. And it's just if somebody has family history, direct family history of medullary thyroid carcinoma, then those medications are not recommended.
Wow. So yeah, actually there is a dose for them. That's why board certified in obesity and endocrinology use them. I mean, it's need you know, there is a tailored dose, the dosing for patient perhaps, and then I am sure that it's already in guideline or FDA approved for that.
FDA approved for weight loss. First, it was FDA approved for diabetes, and then we were all using it off label for weight loss because we knew it worked. And then the FDA indication for weight loss, we have it. So it came. So it's an FDA approved drug for long-term use.
Marvelous, Dr. Rocio. So yeah, I'm interested and I'm highlighting what you said about this actually changing your lifestyle still. I mean, it is actually the core. So it's not just cheating. I mean, it's when you play a game and then you're cheating and have a shortcut. And with these drugs, you can be, you can be thin forever. So it's not actually.
But you know what? It's very interesting because most of my practice is obesity care, and the lifestyle change happens once the patient starts losing weight.
Oh, so they're motivated, or
they're motivated. They're light. They feel lighter to exercise. You cannot ask a patient with severe obesity to go and run for 30 minutes, right? Their joints, their support, it hurts.
Yes.
Their shortness of breath. So I do see the lifestyle change, but after they lose weight, which is really interesting, right?
Wow.
So the motivation is there. The motivation is there, but it's frustrated to do it and not see results. But once they start seeing the results, I don't even have to tell my patients. It's automatically.
Yeah. So yeah, I'm really agree with you because so many out there is an influencer, with thin body, with muscular body, and then they say that you have to work hard for this. So well, actually, many genetic is different. I mean, you will have it different. I mean, when you show it in social media, and then many people with obesity, and then they said, I work hard every day, and then there's no result, no change at all, and then they start to forget it. I will eat more, and then as long as I love it. But you're saying that with this, actually medication help them to get a healthier lifestyle and make them change forever. I mean, not just for how many kilos they lost, but they change its mindset, and then they have to, have a healthier lifestyle in the future and for long term. Wow.
And a healthier relationship with food, right?
Oh.
And a healthier relationship with food. They realize that food is not their enemy. They can control how much they eat. They can enjoy their food without gaining weight. I've never met a patient with obesity that actually chose to have that lifestyle, right? It's a lie that we can think that, they just want to be like that. And no, I don't think anybody will choose to have that lifestyle, right? There's a lot of stigma. There's not just metabolic complications, there's mental health complications, right? Depression, anxiety. So I really, it's very hard for me to believe that somebody will choose that life, right? So they've tried. When they tell you they've tried and they worked hard for it, you have to believe them, and because it's just not feasible for somebody to say that they haven't tried.
Wow. Actually, I really love how you tell people about obesity. I mean, you're very soft of them. I mean, but in the same time, you say that obesity is a disease, but at the same time, you give hope. I mean, you are not just like another influencer that's saying that have body like me, work hard, and then, thank you very much, Dr. Rocio Salas. Well, I really love how you educate people about obesity, and then this is the proof about that.
Thank you. And you know what? I when I came out of medical school, I might have had that same concept, right? That, people are lazy. But through my training and through my experience with my patients, I mean, you realize that we were wrong. That what we thought of it was completely wrong, right? and the patients, it's really sad when patients see many doctors from different specialties and nobody discussed to them about their weight, right? It's always a missed opportunity that you could have had with the patient to discuss about their weight and what to do about it, right?
Wow, yes. And then it's very sad actually when I see people with obesity and then they will have, hypertension drugs, antiplatelet drugs, blood thinner, and then also diabetic drugs, and with your with medication of obesity, they actually can lose their weight and also have a healthier body, and they could there is some a hypertension drug they can lower the dose. Diabetic drugs, is that true?
I always tell my patients, as your waist size shrinks, your medication list shrinks, right?
Oh, cool.
And that's always my goal. I always tell my patients, my care for you is going to be from the inside out, right? My care is what's inside your metabolic health. Whatever happens outside is the cherry on top. And I know that maybe sometimes what the patients come for, right? But I'm seeing it through the inside, right? I'm seeing what can we improve by you helping you decrease your weight. We can improve your blood pressure. We can improve your glucose control. We can improve your cholesterol, your osteoarthritis. The first thing that patient said, my joints don't hurt anymore. My back don't hurt. I can sleep well because my sleep apnea improved. So my care is from the inside out. And all of the other complications that we got comfortable treating, now they can be prevented or hopefully diminished, right?
Wow. Yes. Wow. So yeah, I will repeat it once more. So when you reduce your weight, you have reduced your weight and then you reduce your disease and you reduce your medication, actually, like that. Wow. Yes. Yeah. Well, it's I think it's very strong message for all Indonesian people. We actually have a research here. A survey that there is more than quarter, maybe than 25% Indonesian people actually have central obesity. I don't know in US, but in Indonesia it's like that. And then it's a different thing in Indonesia. In Asia, when you have obesity, you will have central obesity at the most. And I don't know, in US, you will have a big, your whole body will already big. But Indonesian, most of Asian, they're a little bit thin, but they have a big tummy, you know.
And that's metabolic disease, right?
That's metabolic disease, and this is the
type 2 diabetes, same as Mexico. I'm from Mexico, and we have that's a genetic composition. It's a genetic composition that it's more central and visceral fat, right?
Yes.
That's the problem.
Yes. Wow. Yeah. I think this new hope for people with obesity, especially my patient in cardiovascular disease, they will have varicose vein. I just came back from my procedure room. We treat patient with varices, chronic vein insufficiency. But after the laser and the venous treatment, after that, if they still obese, they still have that obesity as a problem, they will come back. The disease will still come back. And then, you're saying that actually when we treating obesity well, we actually help the patient. They will have healthier version of their self.
Yes, exactly.
Wow. Cool. So you're now in, you have your clinic in New York, right?
Yes, I have my practice here.
You can do telemedicine, by the way?
I do telemedicine, yes. I have patients from Qatar to Paris to Paraguay to here in the United States.
Okay, very good. So please give me your number so I can put it here, so when people maybe can consult to you, and then follow the Dr. Rocio Salas, MD, New York endocrinologist, and in Instagram there's so many education about diabetic, about self-care, I think.
PCOS.
Yes. PCOS. Okay.
Yeah.
And about doctor's life.
Doctor's life, yeah.
Cool.
The humanizing part of medicine too, right? Superheroes, not superheroes. We have our, I think that's important.
That's very true, yeah. Humanizing product of medicine, yes. Okay, so I still want to talk to you many things, but I know you have an appointment patient, but hopefully we can talk again later on another interesting topic after this.
Thank you.
Thank you very much. Bye.